My name is Joel Anderson, and I am an associate professor in the College of Nursing at the University of Tennessee. In this presentation, I will provide information about aging and healthcare for older adults in the United States. This presentation is accompanied by a presentation about aging and healthcare for older adults in Japan from Drs. Hiroki Fukahori and Mariko Sakka. This project is funded by a grant from the Japan Foundation Center for Global Partnership to the International Family Nursing Foundation. I am a member of the International Family Nursing Association and co-chair of the Communications Committee. The content of the presentation is solely the responsibility of the author and does not necessarily represent the official views of the Japan Foundation Center for Global Partnership. The learning objectives for this first set of presentations are as follows: to describe trends in aging and the health of older adults in Japan and the United States, and to compare the healthcare systems of Japan and the United States in terms of care of older adults. In this presentation, we will look at trends in aging and the health of older adults in the United States, as well as the healthcare system of the United States in terms of care of older adults. First, let us take a look at trends in aging and health in the United States. People worldwide are living longer. Today, most people can expect to live into their 60s and beyond. Over the next 3 decades, the proportion of the world's population over the age of 60 will nearly double from 12% to 22%, from 1 billion to 2.1 billion people in 2050. The number of people aged 80 years or older is expected to triple by 2050 to reach 426 million. This pace of population aging is much faster than in the past. Every country in the world is experiencing growth in both the size and the proportion of older people in the population. All countries face major challenges to ensure their health and social systems are ready for this demographic shift. By 2050, 2/3 of the world's population over the age of 60 will live in low and middle income countries. This figure displays data from the World Health Organization visualizing the change in and distribution of the aging population globally over the next 3 decades. It's a stunning representation of how the percentage of the population over the age of 60 is growing exponentially. In the United States, we are seeing unprecedented demographic shifts with regard to age. By 2034, adults aged 65 and older will outnumber children under the age of 18 in the United States. This gap will continue to grow over time, with roughly 95 million older adults projected to be living in the United States by 2060, according to data from the United States Census Bureau. Driven by the aging baby boom generation, the United States population aged 80 and older will nearly triple by 2050, increasing to 31 million. The number of people aged 90 and older will quadruple to 8 million. This will dramatically shift the population as illustrated in this figure from the United States Census Bureau, taking our population from a pyramid to a pillar, with impacts on health and healthcare needs as a result of this demographic shift. Both the birth rate in the United States, which is declining, and international migration play a role in these shifting demographics, as seen in this figure from the United States Census Bureau. In addition to changes in birth rates, we are seeing steep increases in life expectancy globally, particularly in high-income countries such as the United States and Japan. However, you can see there are differences by country, with the United States lagging behind and seeing a drop in overall life expectancy during the past several years. When we look at more U.S.-focused data, we see a more refined snapshot of disparities in life expectancy in the United States by sex and the intersectionality of race, as well as the impact of formal education on life expectancy. Black men and women and those without a college degree continue to have the lowest average life expectancy in the United States. These differences in life expectancy are correlated with factors that constitute the healthcare system in the U.S. Now let us shift our focus to healthcare for older adults in the U.S. One cannot talk about healthcare in the United States without a discussion of health insurance coverage. Given the lack of a single payer or national health system, people in the United States must either pay out of pocket for healthcare services or rely on insurance coverage. The sources of healthcare coverage in the United States are illustrated on this slide. This figure is based on data from the U.S. Congressional Budget Office from 2019. People in the United States may have health insurance coverage from a variety of sources. These include insurance funded by the government, such as Medicare, Medicaid, and military insurance, or privately funded insurance, typically through one's employer. Medicare provides insurance coverage for most older adults in the U.S. Medicare was established in 1965 to provide health insurance to people age 65 and older, regardless of income or medical history. Medicare helps to pay for hospital and physician visits, prescription drugs, and other acute and post-acute care services. Medicare plays a major role in the U.S. healthcare system, accounting for 20% of total national health spending and 15% of the federal budget. Prior to enactment of Medicare in 1965, less than half of older adults in the U.S. had insurance to help pay for hospital and other medical services. Many were unable to obtain health insurance either because they could not afford the premiums or because they were denied coverage based on their age or pre-existing health conditions. Medicare significantly improved access to care for older adults in the U.S. and is now a vital source of financial and health security for nearly all older adults in the United States. Medicare spending is expected to grow at a faster rate than in recent years, in part because of growing enrollment in Medicare related to the aging of the population, increased use of services and the intensity of care provided, and rising healthcare costs. The U.S. Congressional Budget Office projects Medicare spending will double over the next 10 years to $1.3 trillion in 2029, increasing to 18% of the federal budget. Medicare covers a population with a diverse profile in terms of demographic characteristics and health status. A majority of beneficiaries are white, female, between the ages 65 and 84, and report their health status as good or better. More than half of beneficiaries are female, but women account for an even larger share of beneficiaries at older ages. More than 3/4 of beneficiaries are white, while 10% are Black and 9% are Latino. As an increasing number of people become eligible for Medicare, and as more people live into their 80s and beyond, the demographic characteristics of the Medicare population can be expected to change in terms of age, but also physical and mental capabilities, financial resources, health status, and medical needs. In terms of health status, a majority of beneficiaries report being in good or better health, but 1 in 4 Medicare beneficiaries reports being in fair or poor health. Nearly half of Medicare beneficiaries live with 4 or more chronic conditions, and 3 out of 10 beneficiaries have a cognitive or mental impairment. 1/3 have 1 or more limitation in activities of daily living, such as eating or bathing, that limit their ability to function independently. Most live at home. However, 5% live in a long-term care setting, such as a nursing home or assisted living facility. Women account for nearly 2/3 of beneficiaries living in long-term care settings, along with a disproportionate share of beneficiaries age 65 and older, and those who are dually eligible for Medicare and Medicaid. Medicare and Medicaid play important but different roles for people who are eligible for both programs. For the low-income older adults who are covered under both Medicare and Medicaid, often referred to as dually eligible beneficiaries, Medicare is their primary source of health insurance. Medicare covers most medical services, including inpatient and outpatient care, physician services, diagnostic and preventative care, and outpatient prescription medications. Medicare does not cover routine outpatient dental care or non-skilled long-term care services and supports, such as in-home care or extended home care and personal care in the community. Medicaid is a need-based program funded jointly by the federal and state governments and supplements Medicare by providing help with premiums and cost-sharing requirements and by helping to pay for services not covered by Medicare. Dually eligible beneficiaries are poorer and have more medical needs than those who are not dually eligible. Most Medicare beneficiaries have limited financial resources, including incomes and assets. A disproportionate share of beneficiaries with low incomes and assets are women and racial and ethnic minorities. In 2013, half of all Medicare beneficiaries had incomes below $23,500 per person. This equates to roughly 200% of the federal poverty level. Income declines with age among older adults and is lower among women than men and among Black and Latino older adults compared with their white peers. Income is higher among married beneficiaries and for those with higher educational levels. Along with having relatively low incomes, many Medicare beneficiaries have relatively low levels of savings. As with income, savings levels are lower among beneficiaries who are female and racial and ethnic minorities. In addition to insurance coverage, one must consider access to care. For older adults, this can often mean access to acute care or hospitals. Data from the American Hospital Association regarding type of hospital are displayed in this figure. The majority of hospitals in the United States are community hospitals. 2/3 of these community hospitals are located in urban areas of the United States, with only 1/3 located in rural communities. Populations in the rural communities in the United States skew toward older demographics. Additionally, the majority of hospital closures in the U.S., which have been increasing in recent years, occur in rural areas, further limiting the availability of care providers for older adults. This also can have a profound impact on long-term care needs, as we will see. Let us explore long-term care for older adults in the United States. According to a poll conducted by the Associated Press and the University of Chicago in 2021, the top concern among adults in the U.S. is a loss of independence as one ages. This is followed closely by having the ability to pay for the care one needs and not being a burden on one's family. Social isolation and not planning enough for one's care needs round out the top 5 concerns. However, you can see adequate levels of concern related to having to leave one's home and having one's social needs met. Each of these are related to long-term care. As with healthcare coverage in the United States, there are many types of long-term care for older adults. Each come with various levels of cost, either to the older adult needing care, their families, or both. Politics and state policies set up variations in services depending on where you live. In one state, there may be a fairly rational plan with a reasonable set of services available and reasonable accessibility to different groups who need those services. In another state, the plan may be more patchwork, and there are many uncovered areas and types of services. This can occur even within the same state, particularly between urban and rural areas. This patchwork has an impact on the long-term care for those who rely on care from family or friends, remote care and adult day services, and home care. For those older adults residing in independent living communities, assisted living facilities, and skilled nursing facilities, policy at the federal and state level has a more direct impact on these settings. A principal goal of long-term care policy in the United States has been to alleviate the high and often catastrophic costs of residential long-term care, for example, long-stay nursing home admissions, and the impact on state and federal Medicaid budgets, as well as costs to the older adult and their family. However, this goal rests on the assumption that older adults can and are able to live at home successfully via existing informal care that is supplemented by a patchwork of community-based long-term care services and supports. Included among current policy strategies adopted by states to reduce these long-term care costs are rationing and targeting of services, shifting Medicaid and other public-funded sources away from residential care and toward community-based supports, and focusing on consumer-directed options or choices that allow older people to self-determine how they use long-term care services and supports. As previously mentioned, long-term care takes many forms in the United States. There were an estimated 4.5 million long-term care workers in 2018. The majority of these individuals were working in facilities, and half were aides or personal care workers. Given the increasing need for long-term care services and supports as the population of the U.S. ages and their needs increase, one must consider the impact on the long-term care workforce and its viability. Currently, the majority of those providing long-term care in the U.S. are female and low-wage. Nearly 4 in 10 are aged 50 or older, and a quarter are Black or African American. This is important when one considers that the impact and risk of chronic illness in the U.S. disproportionately falls on those with similar demographic characteristics, as we saw with the life expectancy data earlier. Moreover, informal caregiving, or caring for one's own family and friends, disproportionately is taken on by women in the U.S. This all has an impact on the workforce providing paid long-term care services and supports. Now let us take a look at family care of older adults in the U.S. Informal caregiving is at the core of long-term care in the United States. Studies have attempted to estimate the economic value of informal caregiving of adults in the U.S. by considering the costs to replace informal caregivers with paid in-home healthcare providers. Informal caregivers in the U.S. provide an estimated $470 billion in unpaid care annually. This far exceeds the amount of funding nursing homes or home health agencies currently receive. As with the formal long-term care workforce, the number of informal caregivers available to assist older adults in need is expected to decline over the next several decades, creating a family care gap. For those older adults living in the community, either independently or with family or friends, long-term care services are frequently supported by funding from the Older Americans Act. The Older Americans Act is considered a major vehicle for the organization and delivery of social and nutrition services to older adults and their caregivers. Congress passed the Older Americans Act in 1965 in response to a concern about a lack of community social services for older adults. The original legislation established authority for grants to states for community planning and social services, research and development projects, and personnel training. The law established the Administration on Aging to administer these newly created grant programs. The Older Americans Act authorizes a wide array of service programs through a national network of state agencies on aging, area agencies on aging, service providers, and tribal organizations. The Older Americans Act also includes community service employment for low-income older adults, training, research, and demonstration activities in the field of aging, and elder rights protection. This figure illustrates how funding from the Older Americans Act is distributed. You can see that nearly 3/4 of funds are provided as grants to state and community programs that support older adults. Of this funding, nearly half is spent on nutrition support services such as home delivery of meals for those living at home, or congregate meal settings for those living in senior housing or attending adult day services. Other ways these funds are used to support long-term care of older adults include transportation services, adult day services in senior centers, access to health screenings, assistance in managing household affairs such as financial and legal services, and other activities of daily living. How the funding is distributed depends on state and local programs and policy, as well as if and how funds are supplemented at the state and community levels. The Commission on Long-Term Care issued a report in 2013 that emphasized the need for a national family caregiving strategy rather than a patchwork of variable services and supports. This strategy came to fruition in 2017 with Congress passing the Recognize, Assist, Include, Support, and Engage Family Caregivers Act, or RAISE. RAISE charged the Department of Health and Human Services to craft a national family caregiver strategy that advances the integration of family-centered approaches across care settings, advances assessment and coordination across transitions that incorporate care recipients and family caregivers, provides information, education, and similar supports, provides respite solutions, and addresses the employment concerns or financial well-being of caregivers. Despite these recent national policy initiatives and advocacy efforts, the development and implementation of caregiver programs and policies remains largely in the hands of state and local policymakers, where there is significant variability. Indeed, it is at the state level where most aging-related policies are administered, such as the regulation of long-term care services and support providers, or programs providing respite services. A novel and promising example of a family-focused approach to long-term care of older adults comes from the state of Washington's Long-Term Services and Supports Trust Act of 2019. This program operates as a payroll tax whereby employers contribute to the trust to result in a benefit up to $36,000 per state resident. Residents in the state of Washington can then use the benefit to purchase long-term services and supports, including adult day services, in-home health, home modification services, and family caregiver education. To date, Washington remains the only state in the U.S. to have formally implemented a comprehensive strategy to enhance the financing of and access to long-term care services and supports, although various other models have been considered in several other states. Despite being recognized and documented for many years, disparities in health and healthcare have persisted and in some cases widened over time. This is particularly true for older adults. Black, Latino, and Indigenous older adults continue to fare worse compared with their white peers across most measures of health status, including physical and mental health status, and the prevalence of and death rates related to certain chronic conditions. Health disparities are symptoms of broader underlying social and economic inequities that reflect structural and systemic barriers and biases across sectors and have an impact on access to health care for older adults at all levels. Social determinants of health, the conditions in which people are born, grow, live, work, and age, are primary drivers of health. These include factors like socioeconomic status, level of education, neighborhood and the physical environment, employment status, and social support networks, as well as access to health care. For example, older adults living in rural communities often have more limited access to health care and service providers, as well as supports such as transportation options, compared with their peers living in urban areas. The rapid increase in the older adult population in the U.S. brings with it many issues that must be considered at the federal, state, and local level. Increased needs for health care and long-term care services and supports require an examination of existing policies that support these programs, including the care workforce. All these issues must be reviewed through a lens that takes into account social determinants of health and health equity. We appreciate your time and attention to this presentation. Transcripts of this presentation in English and Japanese, as well as a complete list of references, can be found on the International Family Nursing Association website.